So we're going to enter the phase of deliberation on the voting questions. To start that, we need to make sure that we have the voting programs running. So I'm going to let Matt walk the panel through that process quickly. That's not on. It's not on.
There we go. So I know several of the panel members have already been able to log in. I see we've already got some votes coming in. But for those of you who haven't, there's a little instruction sheet in your packets right before your voting questions. So you can use either the Turning Point application or the website that is listed under bullet 2. Is anybody having any trouble joining the session?
I'm guessing. I don't know. But how do you know if you voted or not?
Oh, I think you've already voted as long as it's selected. You voted.
As long as it's selected.
Still waiting for 4 more votes, and for any of you who have questions about whether you voted, as long as you see one of the options highlighted, that means your vote has been cast. You can change the vote up until the point where this green box up there says polling closed. Waiting for 3 more responses. Does anybody think that they voted?
I'm curious, what's that all about?
That's the slide number.
I like that.
So we're just missing 1 vote now because I think the choice not at the table.
Or 80% right, there you go.
Level of evidence. No RCT, nothing published.
Okay, you're a troublemaker.
I don't know what's going on here. Yeah, I know, but I have to get my computer to work first. I'm sorry, I'm holding up the file.
Sorry for the delay.
Logged in.
I want to make sure we find out who was born on 4th of July. Died on the 4th of July.
Don't spoil it.
Okay, so I think we're still waiting for Joy now.
Yeah, I'm almost there, sorry.
Okay.
I really have no
We
idea.
both did.
So as you probably already guessed, this is in honor of the upcoming holiday.
Yes. Oh, I'm glad. Okay.
Go. Let's see who. Correct answer is B, Calvin Coolidge. George Washington is an obviously wrong answer. John Quincy Adams and George W. Bush were both born within 2 or 3 days of the 4th of July. But it is only Calvin Coolidge.
Sneaky question.
All right, tricky. Silent Cal. All right. Okay, so with all of the usual and sometimes unusual levels of uncertainty regarding the evidence, we often struggle to boil that down into voting questions that can be informative to policymakers. We usually follow the FDA label as far as defining the patient populations that will be voted upon. But unlike the FDA, we're not here to try to reassess safety and effectiveness. We're here to talk more about comparative clinical effectiveness and the relative strength of evidence behind that. So the first question is for postmenopausal women with osteoporosis and a high risk of fracture. And I will just read that definition for the US FDA. It is, high risk for fracture is defined as a history of osteoporotic fracture, multiple risk factors for fracture, or an intolerance to or failure of other available osteoporosis therapy. That is the labeled indication for the drug. So for that definition of high risk, the voting question, don't worry, we're not going to vote yet. We're going to be discussing. If you've already voted, actually I'd like you to take away your vote, because we're going to deliberate on the evidence, and I want to make sure that you all have a chance to hear each other's ideas, questions, have benefit of input from clinical experts, et cetera. The question will be, though, so that we can get ourselves focused, is the evidence adequate to demonstrate that the net health benefit of treatment with teriparatide is greater than that of treatment with zoledronic acid? Yes or no? All right. So let me turn first to Jeff just to briefly, very briefly, highlight the evidence that was presented in the report and the judgments around that led to the rating that was given to the evidence on this question. And then we will open it up to further comment and discussion. Jeff?
So, in terms of vertebral fracture, I think the main evidence comes from the network meta-analysis. And remember, the estimates from the network meta-analysis mirror those of the randomized trials, so they're very close. Show unequivocally they're better than placebo, but there are no statistically significant differences between either of these agents and zoledronic acid. There was a trend in the Vero trial, as we heard. There was a difference in vertebral fractures comparing teriparatide to residronate, a different bisphosphonate, an oral bisphosphonate that's not typically used for the higher risk patients with osteoporosis. For non-spine fractures, similar finding, improvements versus placebo, no statistical difference between the anabolic therapies and zoledronic acid. And there, the Vero trial didn't find a significant difference either. No data on hip fractures for the anabolic agents other than observational data, which is fraught with issues where, as Dr. Redberg brought up, where you have compliers versus non-compliers. We see benefits all the time that aren't actually biologic, but have to do with differences in the type of patient who is adherent versus non-adherent. So some concerns about that. I think those are the relevant data right now for comparing these agents versus zoledronic acid.
So just to highlight in your evidence tables, in your evidence at a glance.
So yeah, so I would say we're really looking at in table 5 in the evidence at a glance, the row with zoledronic acid. So for abaloparatide, the point estimate was about a 50% reduction compared to zoledronic acid, but credible interval includes 1. Teriparatide, about a 40% reduction compared to zoledronic acid, but again, the credible interval contains 1. Those are for the morphometric fractures, the fractures comparing pre and post lateral spine films. For non-vertebral fractures, which, as we heard from the commenters, are clinically and economically the most important fractures, there was, again, it's that, really, I guess, the third row, the row with zoledronic acid in it. Abaloparatide had about a 30% reduction in those compared with zoledronic acid. Credible interval contains 1, and teriparatide has about a 20% reduction compared to zoledronic acid, and the credible interval includes 1. So trend towards benefit, but not statistically significant. And then for hip fractures, we just don't have data.
Quick comment on harms.
Harms, really pretty minimal. You've heard about the, for zoledronic acid, the primary harm is the infusion reactions. For the injectables, it's primarily the injection site reactions. And you know, in the one trial that had abaloparatide, teriparatide, and placebo, abaloparatide has the most discontinuations because of adverse events writ large, but not hugely different from teriparatide and placebo, 10, 7, and 6%.
So why promising but inconclusive as your
So promising, as you see, the point estimates suggest that there is 20 to 50% reduction in outcomes. And the bone mineral density data suggests you get more rapid increases in bone mineral density, and potentially that translates into longer-term benefits. But only promising because these were relatively small trials, and so the differences aren't statistically significant. We don't have head-to-head trials, which all other than the Vero trial, which again is unpublished and is against residronate rather than zoledronic acid. And some people would argue that zoledronic acid has a more rapid effect. The differences in fracture reduction are modest, if any, between zoledronic acid and the other bisphosphonates. So no head-to-head trials, and then the lack of hip fracture data is certainly what makes it inconclusive, just promising.
All right. Clinical experts, would you like to comment on your view of the key issues that you think that the panel should drill down deeper into as it thinks about this data?
I'm happy to start with a couple points. And thank you, Jeff. In our discussions earlier, we were rating adherence as being actually equivalent. It's actually not. To surprise us, for those of us who do adherence, actually, the IV Zol actually globally as low as 30% in Korea, up to about 60%, while teriparatide, probably in the patients more frightened because they are actually higher risk, actually goes 60 to 90%. Second point is net health benefits, I think, are not only fracture. There are several observational studies, again, which may suggest, and clinicians use that data in their decision making, where there appears to be some also decreased pain as well with teriparatide, possibly due to healing of microcracks. I don't know the answer, but observational. Again, my third point, observational studies. I submitted data, Jeff, which was not put on the slide. I'm one of the authors of a 9,000 patient observational summary of trials with teriparatide globally, which wound up with about over a 2-year period, 56% reduction in hip fracture, which doesn't have the same bias as with a healthy adherer population, as you mentioned, Jeff. And the final thing I think is clinicians are using the data that quality is important as well. You saw from Robin Dorr pictures of the vertebra that had improvement in cortical thickness, trabecular connectivity, and I think that's important. And clinicians use that actually when we discriminate with patients. As I said, if we find by one means or another come up understand that patient is very low quality, we're biased, I think, to try to use a drug that mechanism of action is very different than a bisphosphonate. So I think there's a lot of other, when we talk net health benefit, I think we need to understand net health benefit is not simply restricted to review of a single trial.
Thank you. Other clinical experts, do you have anything you'd like to add?
I did not have input on these questions, but the question as stated is the evidence adequate to demonstrate the net health benefit and treatment of these two teriparatide greater than the treatment of zoledronic acid? So if you are putting your standard as published evidence, then the answer is going to be clear. However, there are definitely subsets of patients within my practice who I would consider, I think the evidence is building that if you have aversion to treatment, someone who's at high risk, and anabolic preceding something like an anti-resorptive zoledronic acid is absolutely the best practice. And that's my clinical expert opinion.
All right. And thank you. And we talked about this a little bit before, but that part of the issue around sequencing and other things are going to be ground zero for our policy roundtable discussion. Matthew.
So for me, this question really comes down to high risk of fracture, and it's that part of the question, and really what you think of what is meant by high risk of fracture. And they have a definition, but I can tell you when you have a patient sitting in front of you, you have to make that assessment. And certainly these things that are considered by the FDA go into that consideration, but there's also other aspects that, does the patient tend to, are they a risk for fall? You think they're more likely to be other comorbidities that could increase their risk for having problems with their skeleton, particularly falls. it takes a lot of things to consider. So there's high risk, and then there's sort of very high risk, and you have to take that into consideration when you're seeing a patient. So,
If I may again speak, I think I had asked actually earlier, we laud you for doing probabilistic sensitivity analyses for increasing risk of fractures, but we would like very much as clinicians to be able to see that data with the addition of new data that's published, which we think is eminently going to be published over the next few weeks to months. I'd like to know that if there is a chance, we don't know that, it could considerably alter the ICER.
Understood. And we are taking very seriously the importance of tracking the data that may be emerging over the next couple months, and we'll figure out a way to make sure that the report is qualified about that pending data and that there's a mechanism for dealing with it when it arrives.
What mechanisms have you used in the past? Have you done reevaluations?
We've done an update, yes. But we also have to remember that the update process is not unique to us. I mean, every payer has its own sequence of when it will update things. And one of the reasons, again, to do this now is because payers have to have some clinical coverage criteria now or around now, and they won't be waiting. So they may themselves want to update, and if we can be part of that process, so much the better. So, thank you. I know that we'll talk more about kind of the patient view of this evidence later on, but it's always a good idea to say, what's that? Is there anything you'd like to add at this point?
Not really.
Okay, thank you very much. Panel, do you have any thoughts about the evidence? What we often benefit from is your own thinking. If you think you know which way you're leaning with your vote, or if you have questions of Jeff or of the clinical experts, now's a good time. Christine.
I'm struck that there's been a lot of conversation about this new evidence that's about to come out.
Sorry, I apologize. We're trying. I think some of these have been turned off so that they can.
Maybe I turned it off.
There we go.
Did
Perfect.
I thought I was turning it on. So, I'm struck by the conversation that's been going on all day about this trial that has yet to be published. And sure, it might come out next week. It might not come out for 6 months. It might not come out for a year. We don't know. And we also don't know anything other than what people are telling us about it. So it hasn't been in a position to be scrutinized by Jeff and his team in the way the other evidence has been. So my feeling is we cannot, sitting today, make a decision on that. And I also appreciate that we're always looking at evidence on a population basis, and yet we do have a patient in front of us, and something might work better for that patient than the other thing that they had tried. And I think we all know that. And so I hear that people are concerned that if we say, oh, no, it doesn't have evidence here, that somehow it'll evaporate from the face of the earth and we won't be able to use it, and that's not going to happen. Instead, what could happen if we said, oh, we've got something coming down the road that maybe is going to show this is better, and so let's give it the benefit of the doubt and say yes. We've now put something on a train that actually has no published evidence to prove that it's better. And right now it's a daily injection. Who knows, sometime soon it may not be. It might be a lot easier. And then what is then to stop the forces of consumerism and capitalism from putting this out to everybody as a, quote, better, more expensive option that actually is not going to do anybody any good? And that is what I see as really the mission of this body, is to put the brakes on the natural forces to drive things forward.
Other questions of Jeff, clinical experts? All right. Do you feel like you have in your head the evidence that you need to think about and the perspectives on it to be able to answer the question? Does anybody? All right. I sometimes do this afterwards, but I'm going to do it beforehand. Anybody who's going to vote yes on this, would they like to describe their reasoning now so that others can consider it before they vote? Wanda?
Yeah, so
I'm sorry, again, we have to ask you to try to find a mic that's close and on.
So this is an interesting one. From a purist standpoint, statistically, I can't say that it's been demonstrated as better. But from the standpoint of the data, when I look at the statistical evidence, the point estimates are compelling, and also the weight of the interval. The weight of the interval actually, for the most part, falls below unity. And I recognize that there are limitations whenever we're sort of comparing across trials, that I'm also willing to sort of put into that equation. And also, I guess the other component that I'm adding in is the evidence on bone mineral density, which, while I understand that's not necessarily the clinical outcome that we most value, it's a very useful surrogate that also helps me to feel more strongly about the point estimate and the, sort of where the balance of data suggests that we're going. So I would say that while statistically not being purist, scientifically, I think there's validity to that.
Good. All right. Anybody who would be wanting to vote no, share their perspective so that others could hear it? Alex?
Oh yeah, I think it's on. Yes. So I'll be voting no because the data suggests there's a non-significant trend towards superiority of tetraparatide over zoledronic acid for a surrogate endpoint, and not an endpoint that's clinically meaningful to patients. Patients don't come to us and say, can you please take serial radiographs of my spine because I'm concerned I'm going to lose 3 millimeters of height. I don't think any patient has ever come to you and said that. Or I really am concerned about the density of my cortical bone. They say to us, I want to be independent. I want to be able to walk across the room. I want to live without pain. And one of the trends that we've observed throughout CTAF meetings is increasing use of surrogate endpoints and lack of endpoints that are meaningful to patients. And that's playing out here. And one of the reasons that I feel like, for the surrogate endpoint, I can't, a suggestion of non-statistical significant suggestion of improvement in the surrogate endpoint, I can't vote yes.
All right. Thank you. Would anybody else like to put out a perspective that they think is complementary to those that might help others? Yes, Ralph.
I think I'm on. Am I on?
Yes.
The only thing I would like to add to Alex's sage comments is that this is a plea for patient-reported outcomes. I'm actually there. I can't imagine an area in medicine that needs patient-reported outcomes in studies more than this, and it's actually it's kind of a sad state that we don't have that yet available to us, because that is, I think, a key metric here. Certainly, we now have that as in cardiology. We need to have this here for osteoporosis.
All right. We're going to return to the question of future research needs again at the policy roundtable as well. All right. I think we should probably, unless others would like to either question or add another comment. Anybody? Okay.
Okay,
Deborah,
then
go
I
ahead.
make a comment to both. Being a geriatrician, I really appreciate that, but I really appreciate your point and the underlying biology. And one of the things that in the perfect world, if these drugs didn't catch anything from a clinician standpoint, for instance, in my patient here, what we see is what has been reported in the trials, and bone density for sure is a surrogate outcome. But if we go not taking using the anti-resorptive first, and then we get faced with the decision of going up that ladder, the effectiveness of the anabolic therapy appears to be less good, and I think she could speak to that point. So just something to keep in mind as you weigh those risks, because certainly very low bone density is a big risk factor, including falls, but it's just something I worry about in terms of the perfect world in biology and optimizing care to decrease fracture risk.
Alex?
If I could just quickly say, as we know, in geriatrics, it's not hard to ask about these patient-reported outcomes, and the argument for a surrogate is much weaker here than it is, for example, in hepatitis C, where there's like a 30-year delay before you see the full benefits of treatment. The benefits are pretty clear. They're pretty. I mean, they're not that clear. They're pretty. The delay in onset is short, so the time to benefit is short. You could just ask patients, do you have difficulty walking across the room? Do you have difficulty providing care for yourself? So I see less of an argument for surrogate endpoints in this case than in other cases.
All right. Let's go ahead and begin the voting process. 9 of you, thank you, have already voted. That's okay. Go ahead and complete your votes. There should be 15. All right. I'll try to advance this way. Vote there. All right. So, numbers. Okay, we'll just keep going. All right. So who's the math whiz? 87% out of 15. Thank you. 13 no, 2 yes. All right. Good discussion. Let's go on to the next question, which may obviously raise many of the same issues. Here are the same lead-in for postmenopausal women with osteoporosis and a high risk of fracture. Is the evidence adequate to demonstrate that the net health benefit of treatment with abaloparatide is greater than that of treatment with zoledronic acid? Now again, some of you have already started to vote, but I just want to, again, let Jeff quickly highlight the tables and if any difference in the perspective on evidence.
I should have been clearer the last time. It's really the same 2 tables. So here, table 5 for the morphometric fractures. So this is the column with abaloparatide at the top and the row with zoledronic acid on the right. So you have a best estimate of 0.44 or a 56% reduction in morphometric fractures with the 95% credible interval, including a 15% increase in morphometric fractures. And I guess I should say we bias these confidence intervals, some people would say, to be relatively narrow because we used a fixed effects model. If we took this uncertainty into account, if you really felt like we shouldn't, or there are enough differences among the populations that we ought to introduce more uncertainty, the point estimates would be the same, but the confidence intervals would be broader. For the more important non-vertebral fragility fractures, column with abaloparatide, row with zoledronic acid, and that's 0.69 with a 95% credibility or interval going from 0.38 to 1.16. And then the same for the harms. I guess I talked about both of them the last time, but abaloparatide was the one that had a little bit more discontinuation due to adverse events in the clinical trial. I will say in response to the earlier thing, the studies that I've seen real world that looked at both teriparatide and zoledronic acid had very similar discontinuation rates at 1 and 2 years, though other studies find different things. So there are different data out there on the discontinuation rates, but you can imagine many patients are not happy giving injections every day.
Are there any other kind of notable differences in the considerations of evidence for this drug as the studies on this drug? You already mentioned a couple.
In terms of this drug versus teriparatide, we have no real-world data, so there's a little more conceptual uncertainty because of that.
More uncertainty around the harms, I guess, just because
yeah,
of the time
I would say that's
practice?
probably the main. I mean, teriparatide, as we heard, I think he said 2 million patients treated, which is a remarkable number, and very, no new safety concerns identified. Whereas abaloparatide, we really have the limited clinical trial base right now, and we don't have real-world data. So sometimes, new signals arise, and it is a different compound. It's related, but it's derived from a different protein, PTH-related protein, and so there may be unintended consequences that turn up in the long term.
Jeff, if I could make one point.
Stuart, can you just make sure you pull that mic just a tiny bit closer?
In your effort just on continuation, you were stating that you weren't sure how patients would continue with self-injection. Actually, in a higher-risk patient who's quite frightened, actually, they're very accepting of that. That's actually in comparison to a patient on an IV bisphosphonate there's a significant instance of APR, and many of my patients say, although we know full well that the second and third time it's going to be less, once burnt, I'm never doing it again. So that's driving some of it. There is an additional, each one has their own issues. I would just point out.
I agree. Thank you.
Again, I hope to visit much of that in the roundtable too, because we haven't even talked much about out-of-pocket co-pays and other things that may also influence adherence and other things. All right, any other questions then, perspectives on this vote as opposed to the previous one? Bob?
I just want to make sure, I was the other yes vote. I'm not leaving Luanda hanging on this on her own. And I think one of the real-world aspects of this is I do feel like I have to bring some real-world analysis to this. I have to bring something extra as a panel member, not just the report that's on the paper here. I've got no gripe against the data. I think the meta-analysis is I can't find any gripe there. I do have a gripe about the one it both ways of most of the drug companies, and I have serious gripes about the world of patient advocacy and how they're supporting real-world quality of life data that Ralph is, and Alex is right. Some of that stuff is stupid simple. The idea that we don't have some of it to go on that goes along with this actual trial data we're using here is like inexcusable to me. And I do put that, like I did in the last meeting, on the patient advocate groups. I think the pushback goes to the drug companies on that, and the patient advocates are the one to do that. But I feel very strongly that I have to read more into this. I have to actually take into account the expert here. I have to take into account the drug company and patient reps. I have to actually factor this into that. My job is to bring a little bit more to this than just the report as it exists on paper here. So with that, that's the totality of it is tilting it to voting yes now. I admit I'm biased. I'm pretty sure everybody else is going to vote no. So, but that doesn't make it any safer to do, which is why I think Luanda and I have to speak up for that. So.
Thank you. Any other comments or questions? All right, let's go ahead and vote then, complete the votes. All right. Same 13, I can do the math on that again now. 13 and 2. 13 and 2. All right. So the next voting question, that doesn't matter. It's okay. We've got one more. We'll live. All right. Okay, so the next voting question is about the two anabolic agents versus each other, which again, we've heard a lot of comment that this is what we should have been looking at. Well, here's the question. For postmenopausal women with osteoporosis and that same definition of high-risk fracture, is the evidence adequate to distinguish between the net health benefit of teriparatide and abaloparatide? We're not asking which one is better, we're just saying is the evidence adequate to distinguish them at all? And Jeff.
Thanks, Steve. So here now you're comparing the first row abaloparatide, first column abaloparatide, second row teriparatide in table 5, and you see a point estimate of 24% reduction in morphometric fractures for abaloparatide compared to teriparatide, with a confidence interval going from 0.2 to 2.3. And for the non-vertebral fragility fractures, first column, second row, a 17% reduction of non-vertebral fragility fractures for abaloparatide compared to teriparatide, but the credible interval goes from 0.5 to 1.5. And in terms of compared mechanism of action is similar, but slightly different proteins, but they both are purely anabolic. Potentially a little higher dose with abaloparatide at the 80 micrograms versus 20, though that's, whether that is biologically different or just refers to the different drugs is a little unclear from the data. And you saw we do have head-to-head data, but for open label versus blinded teriparatide. So you can look at the active trial, so that's Miller 2016. I guess maybe, let's see, probably the best table to look at that might be table E5, where you have actual fracture data. So if you look in the row just under abaloparatide, this is table E5 on page 5, you see the direct comparison of abaloparatide and teriparatide. Vertebral fractures were 0.6 and 0.8% of patients during follow-up. Non-vertebral fractures 2.7 and 3.3, and no hip fractures in either patient group during that trial. There are also wrist fracture, major osteoporotic fracture, and clinical fracture data reported in this. So these come directly from the head-to-head clinical trial, again, with the caveat that one is open label and one is blinded.
Clinical experts, anything about these data that would compare the two anabolic agents that you would like to highlight? No?
We have less data other than postmenopausal women at the moment. Our vote is structured to be postmenopausal.
Right.
I think although there is no data to make us sure, we have to confine ourselves to that.
Okay. Any questions or comments from the panel? All right. It was helpful to hear beforehand if anybody was going to vote yes or no, to have some consideration. Is anybody considering voting yes? Kimberly? All right.
Well, I like the word distinguish instead of greater, because it does give some opportunity to think about it a little differently. And while they're very comparable, or there's a negligibly better trend across all comparisons, which is probably not clinically significant, but the qualities and the ICERs all suggest that teriparatide, say it again, teriparatide, there we go, say it with rhythm, is already the standard of care. And if you look at the dosing cost, the newer drug is actually less, so, and they're being administered differently. So if we're thinking about...
I'm going to cast brain waves in your direction. The costs are not part of this consideration.
Of course they're not. Absolutely not. That being said, patient-centered opportunity and preferences about how they are going to be administered are. And so I think that it gives me an opportunity to distinguish between the drugs.
Right. I'm not trying to push you off your point. I want to invite you to think that when we vote on value, that's where these other benefits and disadvantages that we often want to consider come into greater play, if you will.
Gotcha.
Alex?
Do harms and side effects like or the need for refrigeration with one but not the other, or site reactions and
I would, for comparative clinical effectiveness, we usually would definitely consider clinical side effects.
Okay.
Issues around adherence, complexity of regimen, and patient preference would fall into other benefits or contextual considerations that we would consider in the vote on value. I know it's a sometimes a hard line to distinguish, but that's the way we try to do it. Any other questions or comments? Okay, why don't we go ahead and vote? Is the evidence adequate to distinguish between the two? All right. You seem to have, I hope the machine's not broken because it keeps giving us the same answer. 13 no and 2 yes. All right. Would anybody who voted yes feel that a perspective that they would like to make sure that the report captures for the rationale behind that? We sometimes try to do that. We heard Kimberly's discussion. Somebody else voted yes as well. If there's anything complementary to that that you'd like to introduce, please feel free to. No? Okay. All right. So let's move on to the value votes. Now, these votes are always challenging when a majority of the panel has voted that there is not adequate evidence to say that one is better than the other. But as you all know, when we do a model, we do take point estimates without the full consideration, if you will, initially of whether that overlap of the credible interval includes one or not. We take the point estimate, and that is what is modeled out. So those are the results that were discussed earlier today. So we are going to go ahead and have you vote on value, but you guys are clear that for those of you who did not think that the evidence was adequate to say that teriparatide was better than zoledronic acid, that will weigh importantly in your vote on value. So, let's see, now I'm trying to find myself the tables in the evidence at a glance that would help summarize this question. This is the teriparatide versus zoledronic acid pathways. So do you mind just really briefly summarizing the top line findings of the cost effectiveness analysis for their consideration, and speaking to the mic if you, oh good, you've got one.
Of course.
Go ahead.
So basically the model, as it is built on the results of the NMA and the other data we just discussed, it shows some incremental QALYs, improvement in quality of life and improvement in life years, the expected estimated life years, and also an increase in costs clearly. And if we consider those together, then we find ICERs that are well above the $150 per QALY threshold. This finding is very consistent across the entire range of sensitivity analysis that was done, as well as a number of important scenario analysis that considered patients with baseline risk of fracture that is more than 10 times higher than we're currently in the base case considering. And also when we compare against no treatment for patients who would not take zoledronic acid. I think that's a summary of the cost effectiveness results. Yeah.
So in my even more brief summary, more costs, little teeny increase in QALYs give you a very high incremental cost effectiveness ratio, in this case 941,000. Any comments from the, again, this is on the cost. Oh, you know what, the other thing I should make absolutely sure that we realize from the beginning is that when we vote on long-term value for money, remember, we also include full consideration to these other benefits or disadvantages and contextual considerations. So this is where we would wrap in other aspects of value. Again, this is where it's very helpful to have you talk about some of your thoughts about these and how they do or do not influence your take on the value given the cost effectiveness range. Yes, Stuart, please.
Just ask for us to understand better, because as clinicians, we very often see patients who start an ibuzole who may stop because of side effects, or who develop a fracture that we would ordinarily switch to another mechanism of action, such as an anabolic. So could you explain to us, I'm not trying to understand how in our modeling we actually understood that, because there will be a significant number of people with an IV bisphosphonate that they may not tolerate or not be sufficient.
So in our model, we compared the anabolic versus zoledronic acid. We did not compare further switching of treatments over time. That are decisions that may be made for individual patients. We did compare it against no treatment, so that's something where the model says something about, and yeah.
I guess no treatment is one answer, good answer.
Yeah, and there we find an ISR of $662,000 per point.
Michael? Sorry, can you make sure you find a microphone? Sorry.
I may be asking the same question in a different way. Did you, when you did the quality calculation, did you adequately stratify for the very high-risk patient that clinically sometimes these folks will see? Or is it a much broader all-comers kind of group?
So the quality estimates are applied on age-based strata in the model, starting with 70 years up to 85 plus. We applied quality of life estimates for each different fracture, but a impact of quality of life of a fracture on a given patient is similar for each of the comparators. So if you have a fracture, it doesn't matter whether you got that from while you were on treatment with any specific treatments.
And I might add, I think you were asking more about changes in risk. So the overall numbers include sort of more average risk patients, though higher risk probably than just a T-score of -3, for instance, because most of the trial, we were basing it on these trials of these agents. But then there was that sensitivity analysis where we ramped up the risk of fracture dramatically for the whole population, and we still did not get a cost per quality down below $150,000 per quality adjusted life year.
And what I'm going for is, listening to the discussions both now and before, there's an opportunity for for personalization, I think, here with the right nomograms or set of criteria. And I just wanted to know if this calculation did that, and it sounds like you have.
Right, in the sensitivity analyses, yeah, we ramped up the risk.
Right, and again, to do it clinically is different from doing it from a cost-effectiveness perspective. So so what they tried to do was to, in a sense, create the extreme edge of risk to see how it affected the cost-effectiveness, and it didn't get it down, at least down to below 150. What did it end up being after you ramped it up that high? Wasn't it around 300 still?
Came down to
300, I think.
Yeah, 300.
Around
something,
300.
yeah, close to 200.
Deborah, sorry.
Yeah, I'd like to just put on my geriatrician hat for a moment, in that I think we discussed this on the call with my questions about the cost effectiveness and the time frame, and this is lifelong. And from my clinician geriatrician standpoint, when I look at this question, I also think about functionality of the patient, expected years contributing to society, et cetera. So oftentimes, actually for my oldest who are cognitively impaired, who are at very high risk of fracture, a lot of them would depend on a caregiver administering a daily injectable to increase bone. And oftentimes those people have been treated already, not 20%, but they have been treated with have a history of bisphosphonate use and would be possibly less likely to respond as well. So I think depending on the age, I think your age stratified analysis suggested that the only time it could possibly become cost effective is if your T-score was -4 and you were 85 plus. I think that's a different population than the ones that I'm thinking about who are still functional, still working now, 70s to 80s, who have very low T-scores and are klutzy, and they fall down and they fracture. So I just think it's a big challenge to model and really determine, but I think that those are the kinds of nuances that are really important to consider.
just to be clear, the model assumed that you had a 70-year-old with the risk of an 85-year-old with a T-score of -4 and followed them forward from age 70. So at that higher risk, you're just getting down to about $200,000 per quality adjusted life year, assuming they have 70, but a very high risk.
Right, and when that's based a lot on the cost, as we've.
Right, right.
Yeah, if I could just add, Jeff, I think a lot of said, I agree, you guys did a probabilistic sensitivity analysis, but when the data is eventually published, it's not published now, I would think that there's an opportunity that the ICER could drop even further then, and I think we eagerly await publication of the data when we can have a chance to recalculate.
Paul?
I would say that unlike the first set of questions where one could argue we really would be great to have this upcoming data, I mean, the model assumed already that it's better, that that there's better clinical impact with these drugs, and so I'm not sure. I think it would have to be a dramatic improvement at the current prices, I think, to have any of that data impact my decision here.
Rosaline, here's where we often try to make sure that we're aware of other benefits to patients or disadvantages. We've talked a little bit about whether for some patients it would be a disadvantage or a benefit to get an injection every day versus a once-a-year kind of IV. Are there other perspectives from a patient that you think that the panel should make sure that they think of as they talk about value?
I've experienced all three methods, by mouth, by injection, and by IV. With all of them, very little result. I have been a very fortunate patient in that I've had just very few fractures. I've only broken 4 bones over a period of, since I was diagnosed back in 2004. I've had a lot of other problems related, to osteoporosis or causing my osteoporosis, autoimmune situations. But when it comes to dollars, is what you're discussing now. I've been very fortunate that my insurance companies never gave Dr. Cotto a problem with the therapies that she was prescribing. But the various drugs that I've taken did not necessarily give me the results that I was expecting. They let me down. And like Ms. Strent this morning, I live in fear of breaking my spine or any other bone because the results have been so negligent. I'm still at a minus 3.9 my spine.
Yeah. If I could add,
please.
You mentioned other benefits.
Please.
As a clinician who sees patients with multiple fractures, including my patient was on the podium earlier, I think we're looking in addition for additional, I mentioned earlier, other additional health benefits that influences clinicians' decision making. And I mentioned the observational studies which are prioritized, again, not RCTs, but observational studies suggesting reduction in pain. There are also lots of case reports, observational studies of patients who are having that they're, clearly that anabolics, we think as a consensus, recent consensus published by IOF, do not accelerate fracture healing, but in patients with delayed fracture healing, for example, we might see 2-3 months after the vertebral fracture, still not healed, putting them on an anabolic may get them back on track, put the train on track. So I think in my clinical decision making, I'm using net health benefit as more than simply fracture reduction. And so therefore I am slightly biased in a subset of patients, painful patients, the patient whose fractures are not healing, to be using an anabolic first, get those results, and then induce an increase in BMD, change their patient outcomes, then consolidate with a anti-resorptive.
We will.
Short comment.
Yes.
We talked about surrogate outcomes, and I am not a fan. I always, when patients come to see me, it's about preventing the fracture. But when you have a patient who's concerned about lifetime risk of fracture and they're invested in being compliant with the therapy, you better believe they care about the BMD. And this is why she's talking about not being satisfied with the treatments she's received thus far. And it's unfortunately the best surrogate we have, and I would say as a counter argument for blood pressure and hypertension, which is a huge risk factor for stroke, cardiovascular disease, et cetera, we use blood pressure targets as adequate therapy.
Yeah, I can imagine if your bone marrow density stays low, then you feel like you're walking on eggshells all the time. It doesn't really make you feel better. Okay. Thank you. All right. Any other questions or viewpoints from the panel? Now, the vote here is going to be split between low value, intermediate, and high. I think what we'll do is probably this time we'll go ahead and take the vote, and then we'll do a debrief briefly afterwards if we feel like that would be contributory. All right? Okay. So please go ahead and vote. This is for teriparatide versus zoledronic acid, low, intermediate, or high. Always that suspense about the last vote. There we go. All right. 87-13, I tell you. All right, 13 low and 2 intermediate. All right. Could I ask one of the people at least who voted intermediate to, I mean, the low is relatively, again, easy, rational, if you will, logical from the earlier vote on clinical effectiveness. So I'd probably prefer to have comment on the intermediate votes. It could have been the two people who voted differently on the clinical effectiveness, but if not, Mike?
So I voted intermediate. This would be on the to the left of intermediate towards the low. And I can tell you on my next vote, it will be towards the higher part of intermediate. The reason is, and I was struck actually by Christine's comment on question 1 and then Bob's comment on question 1, because it's the two parts of the equation. You know, there's a pure sense of data and evidence, and we're not there now. We're talking about value and the subjective nature of value. And then there's the importance of taking clinical expertise into consideration, much like the RAND appropriateness criteria does. And so with that in mind, you know, and with a gut feeling, and I've not done this in my head, obviously, if you did a Markov analysis and you actually did have the utilities, the patient-related utilities on this, I think you would get yourself to an intermediate value if you actually had that. Again, you need to do studies with patient-reported outcomes, not surrogates in this disease.
Okay. Any other comments people would like noted for Jeff?
Just a question of information.
Sure.
Were utilities put in the model when you estimated quality-adjusted life years? Yes.
Okay. Joy, you had a question now.
Yeah. So I might be missing this, but this question is about a sequence of one followed by the other versus the one alone. So is that because that was the trial that
Right, it's because the
teriparatide always followed by zoledronic acid?
You probably remember the anabolics can only be used for 2 years.
Right,
So if you're
okay.
going to model long-term effects, you have to give them the
Okay,
benefit of that.
And then there's
plus-
been discussion in the room, but I don't recall anything in the evidence report that compared sequencing one way versus the other. There's sort of biologic rationale for doing the anabolic first, but there's no comparative trials.
We are going to come back again
Yeah, but,
squarely to that
well,
point.
I think there are data showing that bone mineral density gains are less in patients who have already received a bisphosphonate. The bisphosphonates stay in the bone, decrease bone resorption, but bone resorption and bone formation are biologically tightly coupled. And so if you shut down resorption, you can't bump up the building portion as much. That's the understanding of the biology. I'll let the experts comment more, but there are bone mineral density data showing that the sequencing matters. There aren't good fracture outcomes. The first hint are really the unpublished trials that we talked about.
For time, actually, I'm going to continue on to the next value vote, which is the same framing with the broader considerations that we've now had the chance to walk through a bit. But this one's about abaloparatide, so you can look back at table 19, 18, 19, again, if you wish to look at the row on abaloparatide. And I don't think there's probably anything, but is there anything unique or different about the modeling of this agent versus teriparatide that you need to discuss? I don't remember any myself.
There's nothing uniquely different.
Okay.
So, yeah.
In that case, I think partly for time, and please interrupt if you feel like you want to bring something up about this particular comparison, but since we've walked through many of the issues or all of the issues already for the previous comparison, I just want to let you look at the numbers, and then you may go ahead and vote when you feel ready. All right. We are going to have to check this machine. All those in favor of checking the machine, vote. If it comes out 13-2, we're not going to go far. All right. Thank you very much for the votes. I'm going to check the clock. We are running behind, but I think we can catch up if we take a very, very brief break now. So we are going to bring up some additional members for the policy roundtable. I've got 2:04. I would like to reconvene and start literally on the dot at 2:15.